Hello, my name is Mohamed Ashraf, and I'm currently Chief Retina Fellow at the Bethema Institute at the Joslin Diabetes Center at Harvard University. I'm also Assistant Lecturer at the Alexandria Faculty of Medicine Ophthalmology Department. And today I would like to speak to you about ultra-wide field imaging in diabetic retinopathy. So in terms of the grading of diabetic retinopathy, the gold standard has always been the ETDRS 7 standard field. The current ETDRS classification system as we know it was first described as part of the Early Treatment of Diabetic Retinopathy Study, or ETDRS, report number 10. The classification system relied on 7 fields, each of them 30 degrees with some overlap between the fields, and each field was graded for severity of diabetic lesions. And this has long been considered the gold standard, even to this very day, in diagnosing and grading diabetic retinopathy, not just in clinical practice, but also in clinical trials and research projects. The classification system depended on comparing lesions in each field with standard photographs. Now, there are standard photographs for microaneurysms, for new vascularization, for venous beading, and for IRMA. And for each field, the grader is asked to say whether the lesions in that specific field are the same or less than a specific photograph, or if they're worse. And based on that, the diabetic retinopathy classification was developed. So, for example, if the hemorrhages and microaneurysms were less than, for example, standard photograph 2A, and not a single field had hemorrhages or microaneurysms greater than 2A, then that eye was graded as mild. Whereas if there was at least one field where the hemorrhages or microaneurysms were more than standard photograph 2A in 1 to 3 quadrants, or if there was venous beading, or if there was IRMA less than the standard photograph, which was called 8A, then that eye would be called moderate. Similarly, if an eye had microaneurysms and hemorrhages that were more than standard photograph 2A in all 4 quadrants, or if there was venous beading in 2 quadrants, or if there was IRMA that was worse than standard photo 8A in at least 1 quadrant, then that eye was called severe. NPDR was graded whether it was high risk or non-high risk based on also standard photographs. And the most famous one was the standard photograph for 10A, which has been translated into the international classification system as less than 1/3 of a disc diameter. But again, the basis of this is the standard photograph, which was used in the individual studies. The international classification came later, and it aimed at simplifying these classifications. Now, coming to ultra-wide field imaging, it has really changed how we evaluate and understand diabetic retinopathy. It utilizes a scanning laser retinal imaging device and allows the visualization of approximately 82% of the retina in a single image, and allows the imaging of the retinal far periphery. And you can acquire both color photographs and fluorescein angiography images. And this allows us to visualize peripheral non-perfusion with greater ease without having to steer the patient. And as I will show you later on, it has increased the ability for us to detect diabetic progression. So this is what the 7 standard fields would look like, representing the area of the retina visualized. This represents around 30% of the entire retinal surface. This is the same eye image using wide field cameras, and you can see that there's extensively more surface area of the retina that can be visualized beyond the standard 7 standard fields of the ETDRS. And this represents around 200 degrees of the retina, which is approximately 82% of the entire surface area of the retina. And so the advantages of ultra-wide field are that you can acquire this entire area, this entire 200 degrees, which is around 82% of the retina, using a single photograph. You don't need to steer the patient. You don't need to ask the patient to look up, down, to the sides. You can acquire this area through an undilated pupil. You do not need to dilate the patient. And it takes less than a quarter of a second to acquire the image of the entire eye, which is very rapid. So one of the earliest descriptions of the use of wide field imaging in determining diabetic retinopathy severity was a report by Silva et al. From the Beetham Eye Institute, where I currently work. And the study used 206 eyes of 103 patients, and the first question that they were asking was, compared to the standard ETDRS 7 fields acquired using the TopCon that everybody uses, are similar DR severity grades acquired? And they did find that there was a perfect agreement in around 80% of eyes. A perfect agreement means that if I called mild in using one device, I would call mild using the other device, or moderate using one device, I would call moderate using the other device. And within one level, it was 94.5%. Within one level, meaning that maybe one device called it mild, the other would call it moderate, so that's within one level. 2 levels would be from mild to severe. So within one level, it's 94.5%, and that is very, very good. But the study did note a very important fact, which was that around 20% of eyes had discrepancy in the grading, whether it was within one level or 2 levels. And the most common cause for this discrepancy was the presence of lesions, whether they're microaneurysms or ERMA or NVEs or venous beading, outside the 7 standard fields, meaning that they weren't detected using the TopCon and they were detected using the wide field camera. Highlight this: around 1/3 of HMAs, ERMAs, and new vascularizations were present outside the standard ETDRS fields, meaning that they weren't detected using the regular TopCon and standard ETDRS. So this is just to highlight the idea. Now, this is a ETDRS field 3, and this is the extended or peripheral field 3. Now, just to get the definitions clear, if you have more diabetic retinopathy lesions, more lesions inside the ETDRS, more than the lesions that you find in the periphery or the extended field, the eye is said to have a predominantly posterior distribution of diabetic retinopathy. While if you have the opposite, where the diabetic lesions are present more in the peripheral fields than the respective ETDRS field, then that eye is said to have predominantly peripheral lesions. Now, at first it was just a description, but then the other question was, does the presence of predominantly peripheral lesion affect management of diabetic? So they generated a definition, and the definition said that if you have more lesions in the extended field than the ETDRS field, the eye was designated as having predominantly peripheral lesions. And you only need to have this in one field, whether it's field 3 or field 4 or field 5 or field 6 or field 7. You just need one field with more lesions outside the field than inside the field, and that eye would be called. And these lesions were present in around 50% of eyes with diabetic retinopathy. And it's usually associated with an increased DR severity grading in 9 to 15% of eyes, meaning that, for example, there might be an eye that you would call mild, but if you looked at the extended fields and you found lesions and you looked at that quadrant, you would probably upgrade the diagnosis to moderate given the increased number of lesions present in that entire field. So this is a Venn diagram, and it shows us the distribution of predominantly peripheral lesions. As you can see, the most common lesion was hemorrhages and microaneurysms that were present around 94.6% of eyes, followed by ERMA in around 50% of eyes. So this is just an example. So this is an eye that was imaged using the 7 standard fields, and this eye was graded by the grader as having moderate non-proliferative diabetic retinopathy. But when we did the ultra-wide field imaging, there was actually new vascularization or NVEs that were present outside of 7 standard fields, and it changed the grading of the diabetic retinopathy from moderate to proliferative or PDR. And the other question was, okay, so does it affect prognosis? We know from the ETDRS study the progression rates for mild, we know the progression rates for moderate and severe. Do they change when we add predominantly peripheral lesions to the diet? And another key study that was conducted at the Beetham Eye Institute wanted to answer that specific question. So they followed up a group of patients for over 4 years. The study included around 109 eyes. Approximately 50% of them had predominantly peripheral lesions. So this is the group of eyes that had a predominantly posterior distribution of lesions. These are the eyes that got worse, and these are the eyes that got better. As you can see, only 6% of eyes progressed to PDR in the group with the predominantly posterior lesions. But when we look at the group of eyes with the predominantly peripheral lesions, which are highlighted here in red, significantly more eyes showed worsening, and a much larger percentage of eyes progressed to PDR compared to the predominantly posterior lesions. So the study concluded that eyes with predominantly peripheral lesions at 4 years were more likely to have a 3.2-fold higher risk of a 2-step or more progression, meaning a progression from mild to, for example, severe. And they were associated with a 4.2-fold higher risk of PDR. Now, this was even after they corrected for baseline diabetic retinopathy severity, A1C, and duration of diabetes. So they wanted to see why eyes with predominantly peripheral lesions were more likely to progress. Clues were provided by fluorescein angiography, which showed that eyes with predominantly peripheral lesions had extensive peripheral non-perfusion, significantly more than eyes without these lesions. And as shown by these results from a study conducted at the same institute, it showed that eyes with PPL had approximately a 63% increase in the total non-perfusion area compared to eyes without these predominantly peripheral lesions. These results were so fascinating that the drcr.net designed a specific protocol called Protocol AA to validate these results, and the first manuscript from this prospective study has already been published and confirmed previous findings regarding the diabetic retinopathy grading. So Protocol AA has already validated the use of Opto's ultrawide field imaging in terms of agreement rates and in terms of the detection of peripheral lesions. Right now, we're waiting for the results of the 4-year prospective study, which will show us whether PPL are in fact associated with increased DR progression rates. And if these results are validated, then this will result in DR classification changes and modifications, which will incorporate predominantly peripheral lesions into the DR classification system. So in conclusion, ultra-wide field imaging is changing the way by which diabetic retinopathy is being evaluated. Evaluation of the retinal periphery may provide significant additional prognostic value in determining the risk of progression. And finally, the presence of PPL or predominantly peripheral lesions may reflect extent of non-perfusion and account for the increased risk of progression towards diabetic retinopathy. Thank you.